Good afternoon, everybody. Good evening. So you are all very, very welcome to this professorial lecture by our esteemed colleague, Professor David Thompson. It's really good to see David here coming over to give this lecture, and a fantastic opportunity for those of us within the Queen's community to draw around someone with such a wonderful career and presence, not just in cardiovascular care, but also in nursing. So there is a big, thick CV here, David, so I'm going to start reading that, and you don't need to talk, you don't need to say anything. Is that what you asked me to say? But yeah, I was thinking as I drove in this morning, oh, when did I start to get to know David? That's a while ago, and I was thinking back. Yes, it was decades ago, several, not one or two. So, suffice to say, he has been a legend in the field of cardiovascular care and of nursing for his entire career. I do remember the first presentation that I heard you give. It was up at the RCN, and you'd just, I think, become a fellow of the RCN. And Pat Ashworth, who was a legend in the field of intensive and cardiovascular care, was there, and they were very much fawning over David, who had come over to talk about his clinical research. And it was what attracted me to it was that it was so pragmatic. It was looking at the care of vent flows. In those days, we had patients in coronary care units for far too long, we now know, but they would have a vent flow, and it was getting flushed on a daily basis. And David was really interested in what it needed to be flushed with. Do you remember the results? So it was a really pragmatic clinical trial that had a lot of impact, I think, for the patient experience and care and their outcomes. So and that's really been a hallmark of his career, from those kind of smaller scale research projects to those massive collaborative, international, interdisciplinary research projects that really have advanced the care of people with cardiovascular disease. Everybody gravitates towards prevention in the end, don't we? No matter how acute we start out, we realize that we're at a period in time in cardiovascular care, whenever you come in to hopefully save lives and rescue people, you suddenly realize that there's a big tide of them that never get to the coronary care unit, and that's where your efforts are best placed to be, out there in communities and in general practice and primary care, preventing those risk factors from being established and ingrained, and people going on then to an inevitable decline in cardiovascular event, which sometimes ends very quickly, but very often it is a slow, protracted period of ill health and disability that causes significant loss to families and to communities. So you've impacted on that because you've brought together a whole body of research that has looked at like a vast array of antecedents and then the impact of cardiovascular care on people's lives and on the economy and on our health service utilisation. And thinking about some of the projects that stick in my mind about circadian rhythms, is there a pattern in when patients first present with what we would now call a STEMI, a heart attack or a myocardial infarction? Over that career, you have received distinguished honours from the Royal College of Nursing, from the American Association of Nursing, from the European Society of Cardiology, and from many other places. You've worked as far afield as Hong Kong and Australia and Canada. You have contributed and collaborated with scholars from all over the world, from every discipline within our clinical sciences and social and mental health care. More than 700 papers, 15 books. Have been privileged to be in some of those and know the input and heavy lifting that David does on every single publication. He takes it all very, very seriously. He sat on 4 research excellent framework panels. He's contributed to Queen's in the most recent assessment, in which we obviously did very well, and we're very proud, not just of your input to that, but to the collaborative interdisciplinary return that was made, and the successful outcome there that saw us fourth in the UK for the quality of our research and the international and world leading research that goes on in Queen's being recognised because of its interdisciplinarity and its impact. So thank you for that. It has been a wonderful pleasure for you to be with us on the team within Queen's for the last 5 or 6 years. We have enjoyed that tremendously. And many, many people in this room, many students, many staff, many of our alumni have benefited from your shrewd advice, your wisdom, and your experience, and always with a smile and a joke and very much can-do attitude. So that has been really, really important for our school and for the university. So thank you again for that. I think, you know, your H index of 92 just says it all, really, doesn't it? It's just like, get out. Is there such a thing as a H index of 92? But yes, you are, you know, amongst the top scholars in Queen's, amongst the top 2% of scholars in your field internationally. And, you know, and yet you are very much a member of the team here in Queen's. You memorably headed up the staff development committee whenever we needed shrewd advice and input. And you know, you've been a really key member of our team for many years. So I'm delighted to see you come here tonight. I hope you feel that this is a worthy acknowledgement of your contribution and your input here. And certainly we're really excited to hear some more about your career and what you've learned in terms of matters of the heart and mind. Less talk and more action. Thank you.
Thank you. It's hard to follow that. It's a pleasure to be back here in this great university, lovely school, this building, this mural, which brings back many happy memories, amongst such distinguished guests, colleagues, friends, and Michael Brown. Sorry, could you hear? So you're probably wondering why I'm talking about this topic. It's something that I'm very interested in. I've spent all my career actually working in cardiac care. In fact, since the age of 18, which I won't tell you how old I am, but it's quite a long time ago. And one of the things that drew me when I came to Queen's was I remember Frank Pantridge, who was a cardiologist here. And I actually came to visit Frank Pantridge when I was a staff nurse, because he was a pioneer in coronary care, and he established a mobile coronary care unit here. And it was quite a character, if I can use that term. And he made this quote in his biography, which I thought was great. People can be divided into 3 groups. Those who make things happen, those who watch things happen, and those who wonder what happened. And I'd like to think that I'm in the first or second group. And just if you want to know more about Frank Pantridge, he was a very interesting man. He was not just a cardiologist as an academic, but he also won the Military Cross. He's a very brave man, and this book is worth reading. He was the inventor of the portable defibrillator, but he also, as I say, introduced mobile coronary care units. So the outline of the talk is give a brief bio sketch, sort of my professional and academic career, and why I got into cardiac nursing, cardiac rehabilitation. Some background to the heart and mind I'm very interested in, because although I'm a nurse, I'm also qualified as a psychologist, although I don't claim to be a psychologist, because psychologists can get very precious. But I am interested in that, and talk about my research on the heart and mind, and then about heart health and mental health and the absence of in contemporary care, and then particularly psychosocial aspects, including assessment and interventions, and then the implications of this for education, because we work in the university, so we want our research to impact on practice and education, and also hopefully on policy. And then I'll conclude with some comments. So I have a very atypical career, a bit like Michael and Christine, actually, when I heard their presentations. I should start at the outset by saying my father was a clerk in Holy Orders. And if you don't know what that means, it means it was an Anglican priest. And we used to move around a lot. I went to 7 schools. I rebelled. My father wanted me to become a priest, and it was the last thing I wanted to be. And I think it was a disappointment to him. And I was quite rebellious. And I used to start at a new school, start at the top and work my way down. And in the end, I went to a public school, private school in England, and then I was asked to leave, which I won't go into detail about, at 16 and a half. So I was a bit unclear what I was going to do. And my father then had moved to Huddersfield, which is in Yorkshire. Huddersfield's quite an interesting place. It's the butt of jokes, as well as the place of Harold Wilson, who founded the Open University, was a prime minister numerous times. It's also the birthplace of other people like James Mason, the Hollywood actor, who I had the pleasure of meeting. He presented me with my SRN certificate. Sir David Brown, who had David Brown tractors and Aston Martin cars, and the current poet laureate is from Huddersfield. So we moved to Huddersfield. I found out at the new hospital, Huddersfield Royal Infirmary, which had just been opened by Harold Wilson, who was the Prime Minister then, that they were looking for men at the time to try and get men into nursing. And I wasn't sure about nursing at all. And so I decided to work part-time as a nursing cadet. And some of you might have heard the term nursing cadet. They've been reintroduced actually by the RCN, including here in Northern Ireland. I was a bit of a novice and a bit naive, but I really enjoyed it. And then at 17 and a half, Huddersfield was one of the few centres in England. There was one in Scotland at Princess Margaret Rose Hospital in Edinburgh, which Michael knows. But there were very few hospitals that had this as a training course. And the orthopaedic nursing certificate was a 20-month course. And I really enjoyed it. I learned a lot about traction, about splinting, about applying plaster of Paris. I really enjoyed the course. And there were only 6 of us on the course. It was a really, really interesting course. And unusually then, there were 4 men and 2 men and 4 women. And then if you completed that, you could do your SRN, the RGN RN, which was a shortened course. And so I did that automatically straight afterwards. And then if you were a woman, you tended, if you wanted to get to advance in the profession or get promotion, you were encouraged to do midwifery. But it was always post SRN. You couldn't go into direct midwifery training. And if you were a man, it was probably mental health or learning disabilities or something like that. But it wasn't called learning disability, it was called mental subnormality. It's had various terms over the years. So I became a staff nurse when I qualified, and then I did my RMN, my mental health training, all in the Huddersfield area. And one of my colleagues, Tony Butterworth, became the Pro-Vice Chancellor at Manchester University. So some people did very well. Another one, David Skidmore, was the head of nursing at Manchester Polytechnic at the time, which is now Manchester Metropolitan University. So there were quite a few people that qualified and did well. I was a staff nurse in 1978, and I worked. I'd asked that at that time, when you qualified, there were 36 of us in my group, and only 6 of us got jobs because the history of nursing is workforce planning is rubbish, and they always underestimate or overestimate how many nursing places there are. And so we were judged on our ward reports and our exam results, and I was one of the lucky 6. And they said, where would you like to work? And because I'd done orthopedics, I said, I'd like to work in orthopedics, A&E, accident and emergency or an orthopedic ward. And because I've done general training, I said, even a medical ward. And so on said, you'll work on coronary care. And I had to ask where the coronary care unit was because I'd never seen it. And I joined the coronary care unit as a staff nurse, and I really enjoyed it. And I wrote my first article actually as a case study on a patient called Stanley Hepworth, and it's all right to disclose his name. He gave me permission. Who he readmitted to the coronary care unit in those days with paroxysmal supraventricular tachycardia, very fast heart rate. And we used to have to cardiovert him, apply an electric paddle to his chest. And obviously that was very traumatic. And he survived, and I wrote a case study about him. The sister on the coronary care unit felt I was wasting my time writing, why are you writing an article about this patient? Why don't you give more bedpans out and do more bed baths and things like this? It's very ritual and routine then in nursing. And but one day the cardiologist, Ernest Hunt, a lovely guy, appeared, and he sat at the nurse's station while I was running around doing something, a waste of time. And he read this case study and he said, have you ever thought of publishing this? And I didn't know what publishing was. And he said, it's a really good article. You should aim to get it published. So I wrote to the editor of the Nursing Mirror at the time. There were two weekly journals, the Nursing Mirror and the Nursing Times. And I wrote to Pat Young, the editor. And she said, this is a really good article. We'd like to publish it. So that was my first introduction. But the reason I'm telling you all this is because what struck me about Stanley was not the cardioversion and correcting his heart rate, but the psychological consequences of it, to have that repeatedly done. And then I think I fell out with the sister on the coronary care unit, and I decided to change my career a bit. And I'd heard about a charity called the Grenfell Mission, which is now called the International Grenfell Association, which was providing mental health to community centres, well, to communities actually, in rural and remote parts of Canada. So I went to work in Newfoundland and Labrador, and I had no clue what I was doing, but I had to go to London for an interview, and the person that interviewed me told me I would need to buy a sheepskin coat, thermal underwear, gloves, and a bearskin hat. And I turned up at Gander in Newfoundland on an Air Canada flight from London, all dressed in this outfit. And when I got off the plane, it was sunny. This guy came towards me with sunglasses and a Hawaii shirt and shorts. He said, are you the Brit? And I said, how do you know? And then he took me up in his plane. And on the side of his plane, it was an ex-Vietnam War pilot. And he had prepared to meet their maker on the plane. And it was just me and him. And halfway up in the sky, he turned the engine off and said, we're going to go into a dive. It was psychotic, I think. But so that was my introduction. And I really enjoyed Newfoundland and Labrador. But after a while, I felt quite isolated. And I decided to return to the UK, and a job came up at Leicester, in the middle of England, at Leicester General Hospital. Leicester has an interesting health service. It was one of the biggest health services in the UK. It's got three big over 1,000-bed hospitals. And I was appointed first of all, as a charge nurse, and then a clinical nurse specialist, and then the senior nurse of the coronary care unit. And I stayed there on and off for nearly 9 years. But I was there for 4 years, 5 years initially. And while I was there, longer than 5 years. While I was there, I'd done a diploma in nursing from London part-time. And then I decided, why not do something a bit more challenging? I did a part-time degree in nursing, which I really enjoyed and did well in. And then somebody said, why don't you go and do a PhD? And at that time, there were very few nursing schools that offered PhDs. And so I registered in a psychology department at Leicester University to do a PhD. And I qualified in that in 1988. This is part-time. And I had to get special dispensation to submit because it was too early. They said, normally full-time PhD takes 3 to 4 years. So I got dispensation. In 1987, I was appointed a lecturer in a new department of nursing at the University of Liverpool, and I enjoyed that, but I still missed clinical practice. And then in 1990, I was appointed the head of nursing research for a health authority in North Derbyshire, and while there, I got interested in policy, or the lack of policy that was going on in the health service, and did an MA in policy at Loughborough University. In 1992, a job came up, an unusual job, at the Institute of Nursing. And people that don't know the Institute of Nursing, it was a new initiative initiated by the RCN. But some big names have come out of the Institute of Nursing. I mean, Sue Pembury, who was the director, was very good at identifying talent. And I think that's something I've learned, how to spot talent and develop and nurture neophyte researchers and scholars. And I was appointed as a reader in cardiac rehab, partly with the Institute of Nursing, but also with the School of Public Health at the University of Oxford. And my mentor there, David Wetherill, who was a Regius Professor, he'd been at Liverpool, I'd known him at Liverpool, and he was a very wise man, and he was very good to me and to my career. At the Institute, we had people like Alison Kitson, Brenda Rowe, Kate Sears. These are all names that went on as leaders in their field. And this is where I got really interested in cardiac rehabilitation. I'll talk about that later. And then in 1994, I was invited to go for the chair of nursing at the University of Hull. And Hull is the fourth oldest nursing department in England, after Manchester, Chelsea College, and Surrey. Chelsea College became King's College. And I enjoyed it. I was the first professor of nursing there. It was a very political time, because that was the time when old colleges of nursing, old hospital colleges of nursing, were being merged into universities. And so I had to oversee that. And that was quite difficult, challenging. I've always been interested in studying other things. And so while I was there, I did a PG diploma in anthropology and an MBA. Mainly because universities are rubbish at leadership and management, and yet they have management schools, but they're often bad at dealing with management issues. And then, while I've been there, I established a British Heart Foundation Rehabilitation Research Unit and an Institute of Rehabilitation. And I've been approached by the Department of Health to become the first Professor of Nursing Research and Development at the Department of Health. And I told the VC at Hull that I was going to do this, and he was a bit unhappy about it. But the VC at the University of York said, why don't you come to York and bring your team with you? So that's what I did. And I was the foundation professor there. And I enjoyed that very much. But during all this time, I've been an external examiner at the Chinese University of Hong Kong. And they'd repeatedly asked me if I would be interested in going to be the dean of the school there. And that's a very interesting place. Hong Kong is a very interesting place. And in fact, one of my former students, Chen Wai Tong, is now in that role. And the Chinese university has been ranked by the QS rankings as #1 in the world. And I always claim some credit for that, whether that's legitimate or not. But it was a great place to be. And I was there for 5 years. It was quite stressful, because in Hong Kong it's a very stressful environment. University is very stressful. So their idea of working was from 8 o'clock in the morning till 8 o'clock at night, 6 days a week as normal. And on a Sunday to spend that recruiting students or doing PR work. So it was quite exhausting, but I enjoyed it very much. And the Vice Chancellor there, Arthur Lee, was a great mentor to me. I came back from Hong Kong and went to the University of Leicester to be the first Professor of Cardiovascular Nursing in the UK. And I was in the medical school, and it was quite difficult because I was having to sort of mix with the Department of Cardiovascular Sciences, which was headed by Nilesh Samani, who I've known as a medical student, and we got on very well, but Nilesh was quite a strong personality. And I was also in the Department of Health Sciences, and it was quite straddling both departments was quite difficult. And as the only nurse in the medical school, it was quite challenging because a lot of medics didn't really know how to deal with me. And in medicine, I'm generalizing grossly here, but in medicine, their idea of intercollaboration is, a cardiologist working with a cardiac surgeon. It's not necessarily interdisciplinarity as we know. But I did enjoy it. And then I went to Australia to give a talk in Melbourne at Monash University. And I was approached by being Professor of Nursing and Director for a new centre, which was a partnership between St Vincent's Hospital and Australian Catholic University and University of Melbourne, which was a very interesting initiative. And I enjoyed that. And I think we made a lot of headrooms until things went a bit downhill for me, because there was, as always is in these organisations, a sociopath was appointed as in a leadership role, and we didn't get on. And if I leave it like that, yeah, Donna knows the history and the person, but I don't want to be slave for what's the word, slander. And then Donna and myself had kept in touch over those years, and an opportunity came up here, which was great, and the timing was good. And I've enjoyed it ever since. And it's lovely to see many of you here, and it's lovely to see people like Margaret Couples, who I've known a long time, although we haven't seen that much of each other recently. So I don't know if you recognise these two people. One is Aristotle, the Greek philosopher, and the other one is the great anatomist, the British anatomist, William Harvey. And they came up with, I'm just going to give you some background here to the heart and mind. They came up with this hypothesis, the cardiocentric hypothesis, that the heart has a profound influence on emotions, cognition, and awareness. And it's a repository of emotions and wisdom. And I think we all probably know that deep down. Everybody talks about the heart, and it affects the mind and the emotions and cause heart attacks. I mean, it was something that I was very interested in and observant. I used to sit in coronary care when I was in charge of the coronary care unit. We also used to sit around a bank of monitors watching the patients who were there for 2 or 3 days. And I used to think, a lot of these patients seem to come in at certain times of the day. Everybody says, oh, is it high blood pressure, or is it high cholesterol or whatever? And when you ask patients, they'll often say, no, it wasn't those, it was stress. It was emotional stress. And so I was always interested in that. And so this model this hypothesis had great appeal to me. And just to remind people, heart disease is still the major cause of death, morbidity, and diminished quality of life across the world. And yet the focus is still very much on care, but particularly treatment, rehabilitation. It's in all those areas, it's predominantly on the biological, physical aspects, not so much on the the emotional and spiritual and social aspects. And the mind, I think we forget 1 in 8 people living with a mental health problem. And that's according to the WHO, and particularly depression. And now we're recognizing depression is probably a major predictor of heart disease. And heart disease, if you get heart disease, causes depression. So there's this sort of bi-directional relationship between them. And then an area that I'm interested in now, because I'm not very good at concentrating on things, is on this broken heart syndrome, Takotsubo, which is developed by the theory was developed by a Japanese cardiologist. And he noticed that in very stressful events, and he used earthquakes as an example, is a big trigger for heart attacks. And there's a lot of interest in this broken heart syndrome, and it's something that I'm working on at the moment, and working with a team across Europe. So heart disease and mental health disorders, they're the leading cause of disability. They're the biggest health challenges facing healthcare systems. Heart disease is associated with increased mental health problems and vice versa, as I've said, but they impose not just huge and huge economic burden, but also a huge human burden, not just for patients, but for their loved ones, for their families, and so on. And we probably all know somebody that's had heart disease and suffered from it. So I think a good heart and mental health are integral to overall health and well-being. Now, just to bore you for a few minutes, I got interested in this, as I say, very early on, but I wrote my first research paper in 1982, and it was looking at anxiety in patients. And I found that a lot of patients, and it was very sex focused then, it was very on male patients, because that was most of the patients were male patients that had a heart attack. Heart failure was unheard of then. Angina, again, not so much recognized, but certainly people with heart attacks. And I noticed that patients were very anxious, as you would, it's a normal response, but the anxiety changed over, there's a pattern. As they transferred from the coronary care unit to the ward, they became more anxious, and then it tailed off. And then just before discharge home, they had more anxiety. And then during convalescence, they would have anxiety. And I published this in a journal called International Rehabilitation Medicine. And I followed this up with papers in the British Journal of Medical Psychology, not just looking at the patterns, but what were the sources of anxiety. And as I say, their sources were, I think I'm going to die, or I'm going to have another heart attack, or I'm not going to live long. And these sorts of normal reactions that people had. Interestingly, not many people had looked at this. The only person that had looked at it was a rehabilitation physician in Edinburgh called Lorna Kay, who was a pioneer in this. And then I started to look at partners of these patients, the wives, female wives of male patients with this, and the lack of support that they felt they received, particularly during convalescence. If you think about it, on a coronary care unit, you're under 24-hour surveillance. The minute you go home, there's nobody keeping an eye on you, or there wasn't then. And so for my PhD, I developed a very brief intervention that could be given by nurses. They could be trained up very quickly to deliver a very simple program of four sessions of counselling to sort of address anxiety, depression, improve knowledge, satisfaction, these sorts of things for couples, for patients and partners. And it was delivered by nurses, and we did a randomized controlled trial. And when I did it, I got approached by Ian Chalmers, who founded the Cochrane Collaboration. And Ian Chalmers is a neonatal physician who was the pioneer of some of the big trials and set up the Cochrane Collaboration. And I'll talk a bit more about that later. But he was very supportive and felt that my trial was a very high quality one, and I'm a bit obsessional. So I tried to make it it's very hard to do a proper randomized controlled trial, particularly with non-drug trials. A drug trial is very easy. You just give them a drug or a placebo, and are they alive or dead at a year? I mean, that's exaggerating, but that's often the typical medical trial. And to do things like education or psychological interventions, whatever, is very difficult because you can't blind them and so on. And we followed this up with various papers. And then while I was in Oxford, I got a big grant from the Department of Health to develop national guidelines for cardiac rehabilitation. I was particularly interested in the psychological aspects. And so we led the first national cardiac rehabilitation guidelines for the UK and published those in Heart and also in a monograph in the Royal College of Physicians. I was very fortunate to work with a very supportive cardiologist, David De Bono. David De Bono was a brilliant cardiologist, unfortunately died very young from a form of motor neuron disease, but he was a great friend. His brother, Edward De Bono, is the founder of lateral thinking and is a multi-billionaire with islands all around the world. But the two brothers were very close, and I became very close friends with both of them. And then we looked at these guidelines and thought, are these guidelines actually being adopted in practice? Are they having any impact? And so we looked at adherence to those, and we published a paper in the BMJ. And then again, while I was in Oxford, we ran the biggest study across the UK looking at depression and anxiety as predictors of outcome. And we found that patients with anxiety depression have much poorer outcomes than those that don't, which is what we all know now, and probably not surprised, but at that time, not many people did. And I got quite interested in developing scales to measure these sorts of things. So we developed a thing called MIDAS. I had to come up with an acronym first and then fit the terms around it. Thought MIDAS sounds good. And then I thought, what does MIDAS mean? So we came up with this, which is a bit of a mouthful. And we also developed a thing called the York Angina Beliefs Questionnaire, because again, and people like Margaret know this, but a lot of people think that angina is a disease. It's actually a symptom. It actually means chest pain. But a lot of people have misconceptions about angina. And a lot of people with angina are being told, every time you get an angina attack, stop what you're doing, take a rest, and just wait till it goes. And that's probably one of the worst things to do, because what I actually want to do is increase the blood supply to the heart with gradual exercise. And so we did this. We did a study to test this. And we were invited by the Royal College of Surgeons of Edinburgh to give a presentation, and we thought it had gone down really well, but it hadn't, because the surgeons were very happy to have these patients on their waiting list for surgery, and we were sort of reducing their waiting list. So there's a lot of politics in research. And then we got interested with Rod Taylor, who was at Exeter then, in looking at rehabilitation and how should it be best delivered. And do we have to go into hospital to have rehabilitation? What about delivering it at home? And we showed that home rehabilitation is just as good as hospital-based. And then we extended that into rehabilitation for people that were awaiting surgery. How can we prepare them for surgery and make sure that they recover better? And then I won't go on and on about this, but we were quite interested in other aspects of it. And then we did the first Cochrane review of exercise-based rehabilitation in 2001, but we've been repeating them every 4 years, updating them with new trial evidence as it comes along. One of the problems when you do a systematic review, or one of the hallmarks of it, is it always concludes with, we need more research, better quality. So you could make a life out of just doing one Cochrane review and every few years repeating it. And some people do that. And then we looked at psychological interventions and showed that simple psychological interventions like counselling or simple forms of CBT, cognitive behaviour therapy, and so on, are very effective and can prevent patients having more cardiac events, reduce mortality, and also improve their psychological status. And we've been looking at this over the years, yoga, mindfulness, which are very effective treatments, but quite difficult to do. And then looking at the complexity of cardiac distress. People talk about stress and distress, but they're very loose terms and very vague. And when we've tried to ask patients what they mean by them, we've tried to sort of come up with a better definition. And then we came up with a measure of measuring cardiac distress. And then Chantal Ski has just led a new Cochrane review of psychological interventions for people with heart disease in its broadest sense, not just coronary heart disease, but with heart failure and atrial fibrillation, which is heart failure and atrial fibrillation are the sort of new epidemics really in heart disease. And it's interesting to look at this. And Chantal's review has shown that psychological interventions are effective, but sadly that there were no real good quality trials in AF and very few for heart failure. So in terms of heart and mental health, heart health and mental health, or the absence of, there's a clear relationship between them, but it's poorly addressed in clinical practice. At least a quarter of patients have anxiety or depression. Often, more recent papers are saying around 40% of coronary cardiac patients have anxiety, depression. It predicts cause and outcome, as you'd expect. And interesting, in a recent paper in the Journal of American Heart Association, anxiety is associated with a 41% increased risk of coronary heart disease, 35% increased risk of heart failure. People with severe mental illness, like psychosis, are at 53% higher risk for having CHD, 78% higher risk for developing it, and 85% higher risk of death from it. So, these are significant problems. And they're often associated with other things. People don't now present with just one disease. They often have lots of comorbidities. People with heart disease often have diabetes, for example, they might have COPD, chronic lung disease. They often have depression, as you'd expect if they have those diseases. So, but it's often associated with other things like anger and hostility, a thing called the type D personality, which is negative affect, negative mood, and social inhibition, hopelessness, job stress, low socioeconomic status, social isolation. And it inhibits them in performing their normal activities, whether they're work, leisure, sexual, or social, and impacts on their adherence to treatment, which people often forget. And as I've said, it's important for patients, partners, families, carers. And these common comorbidities all affect, I've said, adherence, but also self-care, the impact on healthcare costs and outcomes. And it's only recently, I think it's fair to say, that there's been a sort of raised awareness and increased recognition of the importance of psychosocial aspects. And there's this field developed called psychocardiology, which has been mentioned in Circulation and the Netherlands Heart Journal. And it's starting to take some effect. And we've been trying to raise this in guidelines, position statements, policy documents across the UK and across Europe and in Australia. Psychosocial stress can mean lots of different things, but it can trigger acute cardiac events. It's significant risk factor. It's now recognised by the European Society of Cardiology as a major risk factor for heart disease. It's highly prevalent and it forms a barrier to medical interventions, and it's commonly masquerades as cardiac symptoms. And as Donna mentioned in a kind introduction, I get sidetracked quite a bit, and I got interested in circadian rhythms while I was working in coronary care, because I was convinced patients were presenting with heart disease much more commonly at certain times of the day, certain days of the week, and so on. I got a bit obsessed with it. And these are 4 papers that I led. And the first one was on the time of onset of chest pain, which was a marker then for acute myocardial infarction, heart attack. And we showed, very statistically significant, that heart attacks are much more common in the early hours of the morning. And there are good reasons for that. Blood pressure peaks at that time, cortisol levels are high at that time, and so on. And I thought, what's the top journal to publish this in? And at the time, I saw this journal called the International Journal of Cardiology, and actually David Bono, a colleague, edited the journal. And so I submitted it to there, and they published it. Unbeknown to me, and a group in Harvard led by Jim Muller also did this sort of study, but it was on a smaller sample. It wasn't as sophisticated, I argue, as ours. And he acknowledged that when I met him. But he published his in the New England Journal of Medicine, and he got much more profile. And then I looked at this further and looked at the days of the week. We found that Mondays were much more common. Heart attacks are much more prevalent on a Monday and a Saturday, if you think about it. It's a change to most people's work patterns and so on. And then I started to get a bit carried away and started looking at the effects of weather on these. And I think I lost the plot then. But I think one of my colleagues said, Dave, you need to get a life. Going back to guidelines, in 1985, Andrew Coates and myself, who worked in Oxford at the time, published the BAC, the British Association of Cardiac Rehabilitation Guidelines, and we wrote a chapter in that about the importance of looking at psychosocial aspects. And we did in the national guidelines, which I talked about, which were published in Heart, but also a monograph endorsed by the Royal College of Physicians, the British Heart Foundation, the British Cardiac Society, and the Royal College of Nursing. But this was in 1997. You know, we're now in 2024, and a lot of this is still new to many people. When I was in Australia, we did a position statement on psychosocial risk factors for coronary heart disease, but a lot of cardiologists, and I'm not criticizing cardiologists, a lot of nurses as well, still not aware, or they don't see it as a very sexy subject to address. You know, they'd rather be doing things to patients rather than looking at airy-fairy things like mood and feelings and stuff like that. And just recently, we've published the World Heart Federation roadmap and re-raised this, but whether it has much impact, I don't know. I think one of the problems, nurses, I think it's important to remember that nurses are the people that spend most time with patients, cardiac patients, any patients really, but cardiac patients, they spend more time with them, and they're very adept at looking and identifying changes in people's behavior. You know, psychology is about three things. It's about emotions, it's about cognitions, and it's about behaviors. You know, how you think, how you feel, and how you act. And I think nurses are very sophisticated at doing this, but they don't often acknowledge it and they don't recognize it in their normal practice. But anxiety and depression are very common. A lot of nurses feel that they have to, particularly in rehabilitation programs, they feel they have to have a psychologist there to spot whether depression or anxiety is there and what they do about it. But most nurses can deal with this themselves. Most patients don't need a psychologist to address these sorts of things. Psychologists are very useful, they're great adjuncts, but they don't need to be there all the time. Depression is a significant problem, as I've already alluded to. They often get undetected, and there is a need for screening. The ideal thing would be to do a clinical assessment, but that's very time consuming and you have to be trained to do it. But there are lots of instruments out there that can identify depression and anxiety. And it's using valid, reliable measures that are quick and easy to use. But it's also important to encourage patients to have a positive outlook and for nurses to have a friendly and trusting interaction with them, not just the patients, but the partners. One of the things I found over my career was that partners actually are more distressed than the patients because they're the ones that have to go home and leave the patient in the hospital. So it's important to include them at every stage. And I've said that in guidelines that we've developed, but they're often not. And also to try and gauge their experiences, if they've had these before, how they've dealt with them, their thoughts and beliefs and stuff about them, and to motivate them and commit to any interventions. And there's a range of interventions which I've covered in the attached article in the pack, and I won't bore you with that. But nurses play a key role, and I think they're often undervalued, under-recognised in that. And you know, we tend to focus on these things. These are real things. I mean, in America, I went to a cardiac unit in America, and this was on the menu. And when you say to a patient, you know, only one glass of alcohol a day, you've got to be clear what you mean by that. You know, the size of the glass, for example. So sometimes the information we give is quite vague and not helpful. And psychosocial interventions, again, I think nurses are very good at doing these. They're structured, non-pharmacological interventions conducted by healthcare professionals focused on improving the psychological and social aspects of a person's health. They include talk therapies, some of them very sophisticated. To do CBT, you need to be trained to do that. But there are simple forms like brief activation, behavioral activation that you can use, social skills training, stress management techniques. They're often not considered or done, even though they're very effective. And we should be doing these sorts of things early. It should be needs-led, menu-driven, and tailored to individual need. As I've said, include the partner. Often all patients need simple, brief advice and some form of very brief counselling. And you can deliver that in lots of ways through face-to-face groups, self-help and so on. And now increasingly digitally with the technologies that are available. And at the moment, I'm working on a program to develop a digital intervention of this, which we're trialing. But it's important to determine their preferences, their circumstances, whether it's acceptable to them, what about flexibility, what training needs do people have, and have agreed action plans, goal setting and pacing, which are often overlooked. We try and get patients to do too many things, to change too many behaviours, when really should be focusing on one that's the most important to them and the one that they choose. And in some cases, we're going to have to refer patients to a psychologist, and in other cases with severe mental illness, to a psychiatrist or to a specialist mental health team. These are the sorts of models that can be used. This is one from NICE. This is a stepped care model. I don't know if you can read that, but basically, the more severe the depression is, then you climb up the ladder or the steps. But these are very simple things to do. And lots of trials and reviews, systematic reviews, meta-analyses have shown that these are very effective. And these are some of them. I won't bore you with them. But these are significant sized systematic reviews, varying between 2,000 and 10,000 to 11,000 patients, repeatedly showing effects. So some of them mainly on psychological outcomes, but some on death and morbidity. And then there are numerous trials, and just recently one's published in the journal that myself, Donna, Chantal, Lorena are involved with the European Journal of Cardiovascular, which is a very high impact journal in nursing. And Queen's has got a big presence on that journal. Has shown that a very simple internet-based form of CBT is very effective. So they're effective. They improve quality of life, motivation, satisfaction, knowledge, smoking cessation, social support. They improve those. They reduce anxiety, depression, stress, loneliness, social isolation. Also, physical parameters such as blood pressure and heart rate. Whether they have an impact on death is controversial, because I think some of the trials are not as rigorous as they could be. But I think we're starting to show that. And these sorts of interventions should be an integral part of cardiac care, rehabilitation and secondary prevention. But they're complex interventions. And so they're often poorly conceptualized, described, and reported in journals. And there's a wide variation. Most of them tend to only look up to 6 months duration, and when we really should be looking at long-term impact. And the effects usually, as I say, confined to less than that, not sustained thereafter. And we need to look at the personnel that are delivering them and whether they're competent enough, and what training and so on they need to do. And then look at patient preferences, as I've already said. So what issues are there to still address? And like all research, we always identify more research that needs to be done. And referral uptake systems for rehabilitation, for example, and secondary prevention have not been good. So if you look in Canada, patients that have a cardiac event are automatically enrolled into cardiac rehabilitation. They have to positively say that they don't want to be in rehabilitation. Whereas in the UK, certainly in England and Wales, most patients are asked if they want to take part in rehabilitation, and many of them will say yes, but then they'll drop out, so they don't actually benefit from it. So there's issues about automatic referral and uptake. A lot of it's focused on patients with acute myocardial infarction or STEMI, non-STEMI. rather than people with heart failure and AF. A lot of it's delivered in hospitals, usually for the patient to fit around the hospital system Monday to Friday, 9 to 5, rather than the healthcare system to fit around them. Even though now we've got digital technologies that can address that. A lot of patients have to pay to come to the programs to take part through travel and time, so they don't really benefit from it. There's a lot of interprofessional, not a lot, but there is some interprofessional rivalry sometimes. You know, people think they have to see everybody, a nurse, a psychologist, a social worker, or a psychiatrist. Is that telling me my time's here? Yeah. It's a shame it's not Ed Sheeran. Where I live at the moment, Ed Sheeran is our local musician. Location, you know, should it be in the home, community, hospital, remote? What about surveillance? And what works? One of the things I'm very interested in is one of my former PhD students, who's now a president of a university, Alex Clark, and myself are very interested in this. You know, what works for whom, when, and why? What about contextual factors? What about things that haven't been considered before? And we're actually just submitted a paper to the BMJ about this. And these are interesting topics. We published a paper in the Lancet about it a long time ago, but we want to develop that further because this issue of complexity is quite a challenge. As academics, you know, we can get obsessed with articles, and Donna was saying how many papers I've published. It sounds like I've published a lot, but I'm a lot older than most people here, and some of the papers are very short. But, you know, there's a danger that we get into this mode of thinking, you know. My friends, as a result of our experimentation, we have just lost a dear and valued colleague. On the other hand, we've just gained a publication, and there is a danger that that can pervade universities sometimes. So hopefully, just to conclude, I hope I'm not running out so much time. I think the implications for education policy, and what I've tried to do throughout my career, is try and make sure there are some implications for these three areas, and try to influence them through trying to serve as a role model, as a credible role model. Whether I have or not is debatable. Make sure that teaching is research informed through lectures, presentations, and so on. The promotion of inter and intra professional partnerships and multidisciplinary collaboration. I've been very fortunate. I've worked with great colleagues, nursing, medicine, psychology, statistics, economics, and so on, which I think has enriched my life, and hopefully I've made some contribution to their thinking. And the integration of the patient experience into research, education, and practice. And I think we've always got to remember, as health professionals, that the patient should be at the centre of everything we do and think about, and make sure that we influence things like guidelines, policy statements, and so on. And I think we've been able to do that, and certainly with Donna and people who are influencers, you know, the ESC and the World Heart Federation, and through books, chapters, publications, and so on, editorial roles, these sorts of things that we should be doing as academics, but also making sure it gets out into the wider world. And a key thing is advocacy and lobbying key individuals. When I started nurse training, it was very much like the ones on the left. In fact, you can see Michael Brown at the top in the middle there. But it's moved much more onto a much more interactive form of delivery. And these are some of the books and journals that we're promoting and trying to impact the community. So in conclusion, I'd just like to say the heart and mind, and I hope I've persuaded you this, are inextricably linked. I think we need to take a much more multidimensional biopsychosocial approach to understand this link and to practice patient-centered care. Guidelines need to make more about psychosocial risk factors, and the implementation of guidelines is lagging. We need better quality studies, but also we need to raise awareness of this. So simply put, we need less talk, more action, and your heart and mind work best when they're in harmony. And remember Florence, bless her, keep calm and love Florence Nightingale. She always sort of inspired me, but also we should always be advocating to improve, innovate and inspire. And first of all, do no harm. I think it's an important message to remember. And like all research, it's not one individual. I've been very fortunate in my collaborators across the years. When I was in Leicester, I worked with some great people. In Oxford, I was very fortunate to work with some world leaders in the field. At Hull and York, influence important people. Hong Kong, Melbourne, Belfast, lots of people in Belfast, particularly the School of Nursing and Midwifery, and elsewhere, networks across the world. So I've been very fortunate to have great colleagues. So all research is a community endeavour. It's not one individual. Nobody should take the credit for that. So thank you.
Well, David, who is that man? How spectacular was that? So, what I do need to let you into a little secret, the picture David had of me as a student, allegedly, had him as his sister tutor, delivering the lecture because I was but a child. No, I'm just joking.
He's not.
It's hugely impressive and humbling to listen to that, David. What a fabulous contribution that you've made over many, many years. So we celebrate that, and we want to thank you very much for taking us a walk through your career as a boy of 16 and a half, almost a priest, to where you are today, which is great. And I suppose from a personal point of view, David's been a really good friend to me over many years. He's very wise, a lot of wisdom, and we've had a lot of laughs, some of which are best left unsaid, to be perfectly honest with you, if the truth be told. Fellows of the Royal College, so we meet there frequently and try to contribute and push things forward. But I think you'll agree with me that the contributions David made over many, many years is absolutely huge. So we want to thank you very much for all that you've done, David. And for the future years, I'm sure you've got a lot of mischief left in you yet. And just a little thank you from us for all that you do. I packed it personally.
Thank you.
Just for you. So that brings this professorial address to a close. We want to thank you for taking the time to join us, and there are refreshments outside, so please enjoy.